Okay, this week is about everything related to the small bowel. I actually struggled to decide what conditions to do in this section because, as you guys know, what I like to do with EOR topic lists is organize them into things that almost, in a sense, go together. And that way I can block information up into smaller pieces for my own studying purposes. That's what I did in PA school. It worked really well for me when I was studying in didactic year and even for the pants. So that's what I'm trying to do with this new topic list. Although I will say, like I just mentioned, it's a little bit tough for me to put some of these conditions in the right episodes. And I will probably end up doing a season two just to better categorize things. I know for sure this episode is going to include small bowel obstructions, ileus, hiatal hernias, and GI bleeding. There are procedures that go along with those, but I'm not certain if I'm going to put that in this episode or have an entire episode designated for GI procedures, which may make more sense because there actually is a lot that I want to talk about with these procedures, which could end up being its own episode just in the length. So, that all being said, that's what our episode is about today, and I'm going to go ahead and just get us started. I briefly just wanted to mention the basic anatomy of the upper GI tract, or at least what might be relevant for this episode. As you guys know, your mouth is the start of your GI tract, and then it goes down into your esophagus, your stomach, and then duodenum, jejunum, and ileum make up your small bowel. And then the ileocecal valve is what separates your small and your large bowel. The appendix actually comes off of your cecum, and so I did not put appendicitis in this episode. In regards to your small intestine, that is the longest part of your GI tract, and the duodenum itself has four parts. It has the superior, descending, inferior, ascending. For me, that always made sense because you just go up, down, back, and up, if that makes sense. Superior, descending, inferior, ascending. The first part is intraperitoneal, and then the second through four is all retroperitoneal. The jejunum has a larger diameter and sits primarily in the left upper quadrant, whereas the ileum is smaller in diameter. It's a little bit thinner, and that is primarily in the right lower quadrant, which makes sense, connects down towards that cecum. Now, just to get us started, I'm going to take us through the small bowel disorders and try to kind of have a logical method to the madness here. The small bowel obstruction is what we're going to start off with first. Etiology, this is the ABCs: adhesions, bulges, cancers. So, adhesions meaning adhesive disease. The biggest risk factor for small bowel obstruction is actually previous abdominal surgery. Bulges, that would be hernias of any kind, ventral, hiatal, etc. Cancer, that would be masses at any point in the GI tract that could cause essentially adhesions or could erode into other tissue. The pathophysiology for small bowel obstructions are both functional and mechanical. Functional meaning a disruption of motility. For some reason, the nervous system has decided to stop working for the time being, maybe due to narcotic usage or recent surgery. And then the mechanical purposes would be interruption of intraluminal flow. That would be most common, so meaning things like fecal impactions, tumors, hernias, strictures, congenital bands, volvulus, adhesions, all of that. Your history for this patient is going to be different based on whether or not there's a partial obstruction or a complete obstruction, which is more severe and more likely to cause things such as perforations or bowel ischemia. If there is a partial obstruction or an obstruction that maybe is resolving already, they're going to have intermittent, crampy, poorly localized abdominal pain, probably associated with nausea, vomiting, and constipation. No gas, no stool, nauseated and vomiting, feeling bloated, crampy pain. If they are on the opposite end of that spectrum and they have a complete obstruction, the pain is going to evolve to become constant and increasingly get worse. They may have bilious or feculent vomiting, meaning it'll be dark, it'll smell basically like poop. They again will also have that constipation, so no gas, no stool. On your physical exam, you're of course going to do a really good abdominal exam. You're going to check to see if they are distended, if they're tender, where is the tenderness, how much pressure do you need to apply to have them elicit pain, if they are having any rebound or guarding tenderness, and then you can check for bowel sounds. So if they have hyperactive bowel sounds, they may be in an early stage of obstruction, whereas if they're hypoactive, you may be in the late stages of an obstruction. Honestly, I think that's more of a test question thing. That's not really something we do a ton clinically. Diagnosis wise, labs, you're going to get a CBC CMP, maybe even a lactate. You may add on some other labs if you're considering other issues in your differential, like Perhaps if they're having primarily right upper quadrant pain and you need to work up a gallbladder concern. On CBC, you're most likely going to see a leukocytosis with left shift. CMP, you're going to see various electrolyte abnormalities related to chronic vomiting or constipation, and they may have an elevated lactate, particularly if they have a complete obstruction causing bowel ischemia. Now, for treatment, or I'm sorry, more imaging. Okay, diagnosis, more imaging. So for these patients, they often get abdominal x-rays taken. It's better if they're upright. You're often going to see air fluid levels on CT scan and possibly even x-ray. The order you're going to get is a KUB or an abdominal x-ray. You may see a